Thank you very much, David. We have now until 9:30 to take questions from those present here and also those on the web. So with that, I'll give the podium back to David.
Go ahead, sure. And I guess maybe for the web, you should say who you are. And
oh, okay.
For the
I'm Bob Kaplan from the NIH.
Yeah.
First of all, thanks. I thought that was terrific. And I just wanted to follow up on actually the Elliot Richardson quote along with, the investment issue. So we do know from expenditures in medical care that just pouring more money into things is not such a good idea without some thoughtful plan. And I was curious about where you're pushing with regard to metrics. I mean, what would the metric that what metric would you use to drive this allocation?
Right. So we have a metrics activity, a driver as a part of this, and we've only had a single set of discussions with some of our roundtable members and some outsiders, and I mean. And I think that is still an open question for us about what directions that we might take that would add value. One of the things that we learned in the little scan is that there's lots going on in the metrics area, focusing either narrowly or broadly on population health. I mean, and one of the things that we need to do with others is to probably be a clearinghouse of what those things are. Our discussions focused on there's the traditional kinds of metrics which you saw on my slides, and those are not unimportant. We had a robust discussion about whether we might do more with summary measures of population health, sort of joining mortality and morbidity or well-being functions. There was a robust discussion about health disparity metrics, and a little sense in our group that we talk a lot about the disparities as being equal goal on raising the mean and reducing the variance, but a lot less tracking on some of those metrics, disparities across different domains, so there's opportunities there. There's a lot of opportunities in communicating about metrics and making that clear, but as my talk would indicate, I would be interested in adding to that metric some of these investment targets and benchmarks so that we begin to have some something to shoot for in terms of how we want to direct our resources, again, either in aggregate or at local community levels, depending on their situation. So I don't know if that's, did you have another thought about that, or?
It actually was, what stimulated the question was the quote, the Elliot Richardson quote. I mean, it was interesting that he made that comment such a long time ago, and he said, well, it's hard to do this, and why don't we get started? And I know Martha Gold's here, but she's been saying this in these Iowan reports over and over again for I don't know how many years, that the other committee that on public health determinants of health, public health determinants of health got into this, and we made these recommendations. The metrics are out there, but it's surprising how little implementation there's been.
Well, I mean, obviously, metrics don't produce change by themselves, as the two maps would indicate. So, I mean, they're necessary but not sufficient, and I think that's why today's workshop is so important, because we've got to understand what those challenges are. And you're right, pick some goals and what do we really want to move, both the mean and the variance. But then we've got to align resources, and we've got to develop these partnerships. And like we learned in December at our movement meeting, we have to build relationships, across sectors. The Health and All Policies great workshop that we had in September. I mean, all of that has to move together. I mean, this is not for the faint-hearted, I don't think. But like Elliot said, it's so important. Let's get going. Other comments or questions? Jim, you want to
I'm Jim Nickman from the New York State Health Foundation. It's been enlightening for me to watch the New York Medicaid waiver process, and the way these waivers work is you convince the federal government that you save them money on Medicaid, and then you ask for some of that money back to reinvest in things that could save even more Medicaid dollars. So it's sort of this amusing process. But it could lead to some concrete ideas of how to think about action. Is because what the feds are saying is, first of all, we won't do anything. Well, first of all, the only metric that they care about is reducing hospital admission rates even more. But secondly, you can only do things that there's a strong evidence base that it will reduce hospital admissions. Well, that takes all of this stuff off the table because it's too long run to show that it's going to reduce hospital admissions in the time frame they'd like to see, and there isn't the evidence base that I bet CMS would find appealing. So in some ways, I think getting at that dialogue about Medicaid waivers might be, and what are the criteria for where you invest and what you can invest in, would be one concrete policy discussion to begin to advance some of these issues, like what Richardson said many years ago.
Right. Yeah, well, I think we're going to hear about some of those innovations here today, and I'm excited to get to that part of the agenda. I mean, there certainly is an issue about the length of time for return, and if that is way too short, I think arguably the current 5-year return, it doesn't have to be 30 years, but, for some of the things we're talking about, you probably do have to have a little bit of a looser standard, in terms of what that return should be. But I believe today we will be learning about some of those innovations already underway, and I'm excited about that. Jeff.
Thank you, David. This was a wonderful overview, and I think gives us a lot to think about. 3 quick points. I should do the depressing one first. So I want to end up on the up note. I think we have an intellectual and policy and political challenge in communicating the notion that there needs to be a federal investment, but there are local solutions. As consistent as that may be with our federal system, it somehow just isn't terribly, look at what's happening to the community transformation grants, which could not be more indicative of local control and local decision making. And yet the biggest challenge in defending one of the biggest challenges of defending the community transformation grants was that we can't point to one intervention that everyone is doing. And so we have a real problem just in communicating the diversity of the solutions, even as we describe it in more general terms, describe the problem in more general terms. So that's sort of the slightly depressing one. Someone perhaps from the Robert Johnson Foundation could talk about, and this is getting technical, but if we are going to describe how much we are spending, then we have to be able to consistently describe what we are spending, and maybe someone from RWJF can talk about the Chart of Accounts project, because I think that may help us at least establish a baseline on the public health side of the ledger. And then I guess the more hopeful note that I would end on is, not that I'm suggesting doing the Chart of Accounts is an impossible thing, but a challenging one, is, Jim's concern about Medicaid, and I think yours, David, as well, about the narrow framework they take is, I'd go back to Elliot Richardson and say, why not start? And what we have seen since passage of the Affordable Care Act, and the work that CMMI is doing gradually more and more around population health, the kinds of waivers that are coming in, what states are doing with their state innovation models. Yes, it's within the constraints of Medicaid savings. Yes, it's within the relatively narrow window that CMS provides us, and there's work that IOM and others can do about articulating how we can measure a longer window. But that's starting. I mean, to think that CMS is now is allowing states to submit Medicaid dollars on housing support. I mean, that gets to your social determinants of health in a way that I don't think any of us dreamed CMS would do 5 years ago. And so we're starting maybe in a narrower framework than is the ideal, but we need to seize those opportunities, demonstrate their value, and I think as we show more and more progress and success in that broader from if you think 5 years ago, but narrow as to where we want to be, I think we'll be able to expand that case more and more because we will be creating a culture of health within CMS in a different way. And so I think that's just a tremendous opportunity that we should affirm and build up rather than be worried. And I actually think that we have more hope in convincing the CMS actuary to see this broader vision than we will probably ever get with the Congressional Budget Office. And so we have some real opportunities there.
Thank you. Sonny, I didn't keep track of all the hands. We'll start with Sonny and go around the table, I guess.
Thank you, David, so much for this introduction. So
And you are?
Sandy Magnan from the Institute for Clinical Systems Improvement in Minnesota. So I'm going to go back to your quote from 1997 where you talked about appropriate financial incentives that need to be designed. So what if you were czar at CMS? They certainly designed a penalty for readmissions and they saw that rate go really down. What if you were to czar at CMS and design financial incentives for population health? What would be some of your next recommendations for that?
Well, I mean, I think we're going to hear a lot about that today. I think it's very much in the spirit of what Jeff just said and what we're going to hear from Jim Hester, later today. I mean, within the authority that they have, essentially to expand what can be paid for, moving in a broader, determinants direction, realizing that they come out of a medical care framework and they can only invest in those things that have evidence. But I mean, I think what Jeff just said about the fact that even some things like housing or some of those even are possible now, I think those are the things that we should expand on. I think the bigger challenge is sort of can really, if there are savings to be, do we really mean it that we want to achieve parity with OECD in our per capita health expenditures? And if so, how are we going to get to that? And if we did, how did the savings, get allocated to other health promoting? I mean, that's a bigger question than probably a CMS question, but that's a huge challenge. And I think one we also ought to take on as well. George, your hand was up, I think.
Yeah, I wanted to, this is George Isham from Health Partners in Minneapolis, Minnesota. And along the lines of Bob Kaplan and Martha Gold, who we've been thinking about some of these issues together in this previous IOM work on the for the Public's Health report. And in that report, we looked at this ratio that you have here, the European OECD ratio, social services spending to medical care of 2 and then 0.9 for the United States.
Mm-hmm.
So as I remember that chart, if the spending on healthcare is about double that it is within those other countries, and if you just reduce that to half, I don't say that you just can reduce that by half because that's not an easy thing to do, but let's just say you did that, then the ratio would change to roughly what it is in the OECD countries if social spending remained constant in this country.
Right.
So the question, one of the questions I have is whether, in your judgment, social spending is adequate as it stands, or whether it's inadequate in the country. And then, because it would seem that at least the absolute level may be equivalent, but I'm not sure of that. I'm doing this sort of mental arithmetic,
Right.
remembering the charts. Maybe I'm totally wrong on that.
Right.
And then secondly, the question of, let's say that that's not the case, and you needed to harvest some of the savings from the healthcare spending to reallocate to social services. The challenge of the mechanisms of reinvestment, because obviously a dollar saved on healthcare is not a dollar automatically spent on social services or where it needs to be spent.
Right.
I wonder if you could just comment further on that.
I bet you thought I had a complete answer to that question right at my lips. When I wrote the book 17 years ago, I mean, people would ask me, okay, this is a vision, but how would you do it? And I said, what makes you think I wouldn't have written it in the book if I knew? And, you know, I mean, unfortunately, I mean, really, we haven't made the progress we need to make on that question. I mean, your question about the Bradley paper is an appropriate one. It's a ratio. And what about the numerator and denominator? To me, it's shocking to me. I think it's embarrassing to me that that paper, which is interesting and provocative, but it's a single paper with a lot of flaws. And, you know, it's that kind of thing that we have to rely on, you know, 17 years later. George, my view is that there are certainly some areas of social, and it was an imperfect measure of social services. I mean, it was an incomplete measure. It was what they had to use. So it's just an example of how we need to begin to think about it to raise the kind of questions you had. I believe there are lots of areas, as we learned in our Health and All Policies workshop, within a number of the sectors where the investments are either not enough or targeted enough. I mean, I am so heartened these days by the bipartisan understanding of the early childhood investments, you know, and the need to really begin to, I mean, even get some formulas going. I mean, we'll have an interesting little perspective come out from this roundtable today about the exciting work in Texas on the 1115 waiver in that direction. So, I mean, and the business community in many places is on board with this, and I think there's acknowledgement. But exactly what's the right per capita amount for each of those different kind of social service investments? I mean, I don't know what that is, and I think it's not known in a general way. And I think, but piece by piece and sector by sector, there are pieces I think that we could pull together to identify some of these benchmarks. And George, to the other question about how do you move it from one budget to another? I mean, that is a huge challenge. And we listed the things on that slide that has your name on it too. I mean, what are some of the possibilities? ACO shared savings, some of these Medicaid waivers, can we work with community benefit? I mean, there's only a handful of things that are really possible. I mean, you guys were bolder than I in your IOM report, at least calling for the possibility about transaction taxes on healthcare spending, but you didn't speak, I don't think, to the mechanism about then how would you capture it and where would you put it. So, I mean, I think these are exactly the right questions with, unfortunately, limited answers in 2014. And it's a shame because I think now policymakers in the public and private sector are looking for these answers and interested in finding them, and to the degree that evidence drives policy, open at least to some of those findings. And we need to do a better job. So that's a non-answer to a great question, but it took me 2 minutes to do that. Any other last-minute comments or questions? Michelle.
So I just wanted
And
to
you
follow-
are?
I'm Michelle Larkin with the Robert Wood Johnson Foundation, and I just wanted to follow up on the chart of accounts piece. It actually grew out of an IOM series of reports that Martha and others participated in, looking at, for the public health, investing in a healthier future, and in particular looked at how public health departments and agencies actually are able to track resources, their expenditures, their inputs. And, you know, one of the things that came clear in the report was that we needed to do some work around a chart of accounts to get a sense of what comes in from where and is used for what purposes, and some standardization about how we actually capture that information without overburdening the agencies, which are already, quite frankly, working very hard with limited resources to get the job done. So there are a group of public health experts working together to sort of develop that and think through what needs to be in it. And I need to check. I actually just sent my colleague who's running this from our shop a note about when they're expecting that should come out. If anybody has insight into that, let me know now, but I will share it with you when I hear back from Paul.
Yeah. So that's terrific. And I think what I'm suggesting is we need to put that idea on steroids and expand it to all the health promoting sectors so that we can begin to get our mind around the totality of the resources that we're going to need to, again, change the colors of these maps. Okay, I think it's time to move on. So thank you very much.